Welcome everyone to the Merit Education Rounds. I am Dr. Elif Bilgic, and I'm an education scientist and assistant professor in the Department of Pediatrics and the McMaster Health Education Research Innovation and Theory, or the Merit Center. The Merit Center is an education services center in the Faculty of Health Sciences dedicated to advance health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. Although today's education round is virtual, many of us in this event are connected by the land on which we work. So I take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Belt. That wampum uses the symbolism of a dish to represent the territory, and one spoon to represent that the people are to share the resources of the land and only take what they need. Before leaving the stage to our esteemed guest today, I will provide a brief introduction. So the title of today's education rounds is Don't Make Waves, Charting the Downstream Effects of Educational Structures and Interprofessional Learning. And we have Dr. Arden Azim as our speaker. Dr. Azim is an assistant professor and clinician educator in the Division of General Internal Medicine at McMaster and a clinician scientist with the Merit Center. She has trained as a nurse prior to entering medicine and completed her medical degree, residency, and fellowships all at McMaster. And she does hold a Master of Health Professions Education from Maastricht University. Her program of research focuses on interprofessional learning across the spectrum of health professions education, with a particular interest in simulation-based learning and the development of interprofessional competencies in the clinical workplace. With her expertise in mind, the rounds today will focus on examining the downstream effects of educational frameworks and practices on interprofessional learning, exploring how these structures inadvertently shape which interprofessional competencies are cultivated and which remain at risk. It will highlight interprofessional conflict resolution as an area of vulnerability and outline a path forward to address this critical gap. Now, during the rounds, feel free to use the chat for comments and questions, as I will ask those during the Q&A period at the end. Also, during the Q&A period, you can ask questions by using the hand raising function as well. So without further ado, Dr. Azim, please go ahead.
Great. Thank you so much, Ella, for the introduction. And thank you, everyone, for joining today. I'm very excited to be doing my very first merit rounds. It feels a bit surreal to be on the other side now, giving this talk instead of attending it. And I'm looking forward to discussing my past 4 years of research on interprofessional learning in postgraduate medical education with all of you. And I'll preface this talk by saying the past 4 years has been a lot of time unpacking a problem, and maybe the next 4 years will be unpacking the solution. But I think this is also then a great group to share this work with because with all of you being able to bring some fresh perspectives and ideas and solutions, this persistent, sticky problem of interprofessional learning. I have no conflicts of interest to declare, but did want to acknowledge some funding sources, notably the Royal College CanMed's AMS grant, which has supported a bulk of this work, along with the Parveen and Wasi Medical Education Grant and Division of General Internal Medicine AFP grant. I also wanted to build an Ellis Land acknowledgement by recognizing that in the spirit of interprofessional learning, it's also valuable to recognize Indigenous ways of knowing and the many different forms that knowledge can take, and as a reminder that collaboration begins with respect and understanding for different ways of knowing and caring. So I'll start by asking you all to consider this case where we have a resident who transitions to their very first block as a senior. They are encouraged, you're a senior now, take ownership, coordinate the team, show leadership, drive discharge planning for tough cases. And in their mind, they go ahead and do exactly that. They're motivated, they show leadership, they're efficient, they're being a good senior resident. But after this, concerns get raised about their collaboration. There was friction with the nursing staff. They didn't get along great with the social worker. There's nothing egregious, but ultimately, in navigating the transition to leadership, there is this perception that they don't get along with the team. The feedback from the supervisor ends up framing this as a professionalism issue. It goes on their evaluation. They have a talk with their program about professionalism. On subsequent rotations, then the resident takes a step back. They disengage during their multidisciplinary board rounds every morning. They are polite, they get along, they lean on their staff to push forward tough discharges and challenging cases and say to themselves, well, when I'm staff, I'll have more authority. In this case, the very thing we asked them to do to show leadership led to negative consequences, and their response was to retreat into what felt like a safer, but arguably more siloed way of operating. And I've run into this case in varying forms, from peers during residency, as a new attending and supervisor, and with residents on enhanced education plans. And it raises this question, what if there's something in how we've structured interprofessional learning in postgraduate medical education that's driving this? What if there's something that's driving us to let it slide, go along, and then sort of rely on this idea that as doctors, we might have power and authority later? And I think this quote to me, when I reflect on it from an interview a few years ago, really resonated. I've struggled a bit after becoming staff. I spent so much of my residence trying not to get flagged, not get in trouble, not make waves, and I finished being like, great, I get along so well. But as this learner points out, or new attending, they wish they'd spent less time worrying about getting along and more time thinking about how to work together. Because the worry here is not just how this affects individual medical trainees, not just how it affects the team they work with, but also the bigger picture of the team patient system outcomes, both while they are trainees and later on in practice. For some of you here, you may be familiar with interprofessional learning, but I'll share this sort of classic definition from the World Health Organization, which is when students from two or more professions learn about, from, and with each other to improve collaboration and health outcomes. And this is really expanded to include the idea of anyone, not just trainees, but students, learners, practicing health professionals who are learning together to improve care. But in my case, it's actually one student from two professions learning about, from, and with myself. So before medicine, as Elif mentioned, I trained and briefly practiced as a nurse. And so here I am in my rotation on the left side at St. Mike's Neurotrauma ICU as a nurse, and then my first day of medical school. And I remember going through the interprofessional education curriculum as a nursing student and sitting in these workshops and small group sessions, and everyone was respectful and curious and asking the right questions about each other's roles. And it was collegial and polite and optimistic. And then I stepped into clinical rotations as a nursing student, and that sense of collaboration didn't quite hold. The silos were there, the hierarchies definitely felt present. We were still mostly professional and polite, but it felt often like working in parallel rather than truly together. And I remember very distinctly that the implicit and sometimes explicit messaging in my educational nursing program was, as a nurse, you are in many ways the leader in the patient's care. You are there at the bedside. You carry the most knowledge. You bring everyone's perspective together. It is your role to speak up, to advocate, to challenge, to protect your patient. That's what we're going to assess and evaluate and look at. And then I went to medical school, and it was a little bit different. We still sat through the same workshops and simulations, and it felt very much the same in the interprofessional education curriculum. And then as I transitioned into clerkship, it was the same messaging, but from a different side. Your role is to be respectful and to listen and be polite, but ultimately, you carry the responsibility. You're a leader, you have autonomy. So get along with everyone and then make the decision that you need. And I interviewed a resident for a study a few years ago who had also trained as a nurse and, in fact, had the same disorientation navigating the switch in educational messaging. And this resident noted, in fact, in my nursing education, the focus was on the registered nurse as a leader of the healthcare team, which is an interesting perspective to come to now as a medical professional, where now we are, in fact, trained, we're the leader of the team. So once again, it's the same person, two professions, two educational training programs, two completely different stories about who leads, two completely different stories about how we should be collaborating and interacting and what is valued and what's not. And I think for me, as a little bit of reflexivity here, having been educated in both professions has given a very particular vantage point on how our educational systems shape what we think about collaboration and how this is actually translated to learners. And that contradiction has stayed with me because to me, it captured something important about how collaboration is navigated, developed, and experienced. We all talk about teamwork through our own lens, and this defines what leadership looks like, who holds authority, what things like shared decision making mean. And these ideas aren't just personal attitudes we carry, they're actually baked into the framing of our education. And then, this perspective, the ability to hold these dual perspectives on things like leadership and power. Another resident I interviewed in a previous study who had trained as an occupational therapist before going into residency stated, felt that they had an easier time because they came in with a knowledge of what it was like to be in a position as arguably less of a leader and felt that they knew how to avoid this trap that they saw where you become nice and easy to get along with, but when push comes to shove, you can't really work through disagreements or share power. And, I like to joke that my superpower for my nursing training is being able to start an IV. But as I've progressed through my training, I think it's been really more about having a more expansive view on professional knowledge, expertise, and leadership. And so to me, the question has become, how do our educational systems shape the ways that collaboration unfolds in the workplace? And how do our learners come to inhabit, interpret, and negotiate their roles within teams? Um, to bring this back to some of the history underlying interprofessional learning, this is that to Err is Human report from 1999, all about how we can reduce medical errors, improve safety. And here, even back then, effective teamwork has been framed as central to improving safety and system outcomes. Train in teams, those who should work in teams. This is how we improve patient care, reduce harm. And then even more calls to action. Working groups reports have followed the World Health Organization in 2010, accreditation expectations, working groups, calls for better teams in primary care. More recently, the Canadian Health Workforce Crisis Report called for teams to work with a full scope of practice. So interprofessional collaboration, being able to sort out this problem of learning to work together is supposed to be this panacea for patients, system outcomes, workforce attrition, and burnout. And we've responded in health professions. We've built infrastructures. Every university has their division related to interprofessional education. We've built curriculums, workshops, simulations. There's tons of research and literature out there. And I've been part of this movement too, as the interprofessional education lead at our Sim Center for 5 years, designing these simulations that were popular among learners. They fostered positive attitudes, readiness. But all of this is a lot of investment of time and resources and effort at the undergraduate or the pre-licensure level. So before the transition into the big transition into the workplace. And the question remains, despite all of this, are we actually further ahead? Well, according to the literature, we've fostered positive attitudes, confidence, self reported readiness for what that's worth. But despite these decades of investment, the transformative potential and promise is maybe largely unrealized. This maybe points to some kind of fundamental misalignment, something that's happening not just in the IPE curriculum, but more broadly in our structures and in that transition to the workplace. So it's not a dose problem. We don't necessarily need more curriculum, but we see these patterns, these persistent hierarchies. In the case of our resident, collaboration sometimes frame more as getting along rather than shared practice. Parody and Whitehead wrote this 2018 paper, Beyond the Lamppost, a proposal for a fourth wave of education for collaboration. And here they criticize this idea of a third wave of interprofessional learning, where the focus was on let's pile more workshops and curriculums and sessions to fix individual practitioners. And they called for a shift to learn teamwork in practice settings among those who are already aware of their roles. And critically, they also called for recognition of power and conflict and interprofessional learning. And if we consider what effective interprofessional collaboration actually requires, and we go to one of the frameworks that defines it, in this case, the Canadian Interprofessional Health Collaborative Framework, it means seeing yourself as part of a broader team, not just leading one within your profession, navigating disagreement productively, not just avoiding it, sharing power in decision making, not just consulting someone else before you go and make a decision, but somewhere we might be teaching people instead be polite, get along, not make waves, use your power when you have it, and calling that collaboration, rewarding individual skills, and questioning why we struggle with shared leadership and productive disagreement. So, if we accept that maybe the workplace is a more appropriate, supported by literature, a good place to focus on interprofessional learning, and that we probably need to look somewhere a little more senior than our undergraduate or pre-licensure students. And as I am worried that the problem might be somewhere, some part of the problem in our educational systems or structures, then I found postgraduate medical education, so medical residency, to be a really interesting space for this question. And I recognize that postgraduate medical education is just one piece of a bigger puzzle. It's just one profession, it's just one stage of training, and there's so many questions that remain that I won't even dare to tackle in this talk. Does learning at one stage translate to the next? What carries over into practice? The classic question, what does this mean for patient and system outcomes? And maybe it's also a little bit self-centered because I just finished residency not too long ago. So all the challenges and tensions about being a resident and learning interprofessionally still feel very fresh. But I do think postgraduate training is really interesting to look at educational structures because these learners occupy a bit of a unique liminal space. They're trainees and professionals. They have growing autonomies, they have responsibilities, they have tasks, they have roles in the workplace. They have a stronger sense of professional identity than a pre-licensure or undergraduate student, but these identities are still very much evolving with lots of room for negotiation. Over anywhere from their 2 to 7 years of residency, depending on how long their training takes, they'll move through transitions in seniority, and each time will be able to renegotiate their roles, identities, their framing. So, but to leverage this richness and to understand these structures, felt that the first step was actually mapping where and how interprofessional learning was happening in postgrad and what educational structures were shaping it. And this meant starting with examining the very architecture and blueprint of postgraduate medical education, because just like other forms of health professions educations, ultimately these rest upon these competency frameworks that define what we need to learn. So, starting at the source, went to explore postgrad medical interprofessional learning at the framework level, recognizing that as much as most of it's occurring in the workplace, postgraduate medical education, the architecture is built around a physician competency framework. And this also answers a call dating back to 2011 about the future of medical education in Canada that asked for an exploration of how interprofessional learning was structurally embedded in postgrad. So in Canada, and some people here may be quite familiar with this framework, but the CanMEDS framework as our physician competency framework, and it defines 7 roles that a physician is expected to seamlessly integrate to advance patient care: professional, scholar, health advocate, leader, communicator, medical expert, and collaborator. And the physician as an individual is centered within this framework, with the idea that a competent physician should be able to seamlessly integrate all these roles to advance patient care. Of note, this is a 2015 framework. There's a newer one in the works, I think, for Believe next year. And in contrast, for us, the Canadian Interprofessional Health Collaborative Framework defines the competency domains for effective interprofessional collaboration: team function, interprofessional communication, clarification, collaborative leadership, conflict resolution, and patient family centered care. The newer version is on the right from 2024. This work was done based on the timing using the older version from 2010, but they're generally quite similar. They center the team, the ultimate goal of relational care, collaborative partnerships to advance patient outcomes. So, to explore how these two frameworks intersect, sort of using this CIHC framework as the idea of this is interprofessional learning and looking at how that was represented within the architecture of postgrad, we conducted a Delphi study with 16 expert informants that included authors of both frameworks, with the question of where do interprofessional competencies sit within CanMEDS. There's 38 sort of subcompetencies or competency descriptors across the 6 domains of interprofessional competencies, and only 5 of the 38 actually met the threshold to be represented in CanMEDS, and most aligned with the communicator role, not the collaborator role, as you might expect, because the collaborator role was intended to actually encompass collaboration with both other physicians and other health professionals. And only 3 of the 6 domains of interprofessional competencies were represented: interprofessional communication, role clarification, patient family centered care. So while the physician competency framework CanMEDS does reference collaboration and communication, relative to the CIHC dedicated interprofessional competency framework, these expectations were insufficiently explicit and weakly operationalized, which might in turn make curriculum and assessment design difficult. But if we looked even more closely, even interprofessional communication was only kind of partially represented. Communication between physicians, so intraprofessional, and physician and patient was explicit, but communication with other healthcare providers was not explicitly present, which is really striking because it's such a fundamental skill. We all share this assumption. I mean, I think almost many of us here take it for granted that effective interprofessional communication, talking to other healthcare providers, is inherent to being a good doctor. But somehow it wasn't found to even be explicitly embedded in the foundational architecture of postgraduate training. And this gap to me illustrates how this uniprofessional framing of education can create blind spots that we don't find for years. So, competencies that align very nicely with a uniprofessional performance, in this case, individual physician, fit comfortably in the framework. Patient centered care, where the physician establishes goals. Role clarification, when you understand your own role. Communication, when you communicate effectively with the patient. But what's maybe missing is an orientation towards the team function, collaborative leadership where power is actually shared, conflict resolution as a productive team process, because these require stepping outside the frame of what makes me a better individual physician into how do we function better as a collective team. I am not the most talented graphic artist, but as I was playing around with these two frameworks, I found this reimagining of how the two frameworks intersect and interact to be interesting. If we sort of shift how the competencies are represented, the interprofessional competencies, and the ones that are the most individual based: physician patient communication, knowing your own role, establishing a patient centered care plan, these are the ones that are represented in physician competency frameworks, and the more complex team based ones do not. And the implication here and the risk is, again, that if these are not in the framework, they may be less likely to be prioritized downstream in the curriculum and what gets valued and reinforced in the workplace. And that shift from the individual to team orientation may be what's missing at the framework level. Okay, so there's gaps in the framework at the highest level, but maybe things sort themselves out downstream. Being optimistic, sometimes things get addressed within the curriculum, someone notices a gap, or even spontaneously in the workplace. So the next question is, does some of this work itself out in the next spot downstream in our curriculum? So, to do this, we surveyed program directors across Canada and asked them a series of questions about how interprofessional learning was addressed, both through formal, structured, so an organized learning event, or informally in the workplace through the natural course of clinical rotations. We asked about what interprofessional learning looked like and what competencies were addressed, and had 31% of program directors across Canada reply across a full breadth of different types of programs. Most programs had reported having some kind of formal interprofessional activity, academic half days, so having one of the half days that happen weekly, so just one or two across the year, workshops, team based simulations, patient safety rounds. Most happened separated from the real workplace, and only a minority, only 28% actually involved other health professionals in design or delivery, which is, kind of points to the fact the same logistical resource challenges that have persisted in the traditional models of undergraduate interprofessional learning stuck around here. And when we asked what interprofessional competencies had they chosen to target with these learning activities, the top three were patient, family, community centered care, performing one's own role in a culturally respectful way, and basically quality improvement workshops or sessions. And what's interesting is that these align very nicely and tidily with the sort of individually oriented aspects within CanMed. So again, I'm going to establish a goals of care as a doctor with patients and families. I'm going to establish a patient-centered care plan, forming my own role in a culturally respectful way, and then QI, patient safety, which are sort of clearly laid out as expectations. So these are all things that still keep the individual at the center. And, unsurprisingly, what I think certainly doesn't come as a shock, recognizing that residency happens in the workplace, the overwhelming majority of program directors said that informal workplace learning was a primary source of interprofessional learning for the residents. And this probably seems obvious because, of course, things happen informally on the wards, on the teams, and operating rooms. But when asked what competencies they felt were best addressed informally, program directors pointed to interprofessional communication, team function, and role clarification, which are important, but are also the ones already somewhat represented at the framework level. And when we asked which competencies they felt were least likely to be addressed through informal learning, they highlighted again collaborative leadership and conflict resolution, which were kind of missing at the framework level. And now those concerns might not work very well in the workplace. And these are those more complex relational competencies that require genuine team orientation. And as one program director put it, if it's not in CanMEDS or in an EPA or objective laid out by the Royal College, it's unlikely to get much attention. So for some of these more complex team-based competencies, we just have to assume they'll just happen in the workplace. So there's this assumption there, but without any kind of structure or knowing where it's happening, the worry is, how do we make sure learners are not defaulting to what frameworks and curriculums reinforce, which is that individual physician orientation? And it kind of reads a little bit like this: cross our fingers, hope for the best approach to the learning. But then again, maybe these gaps still work themselves out from the perspective of learners. It's an interprofessional workplace. We have all that rich undergraduate interprofessional education. So maybe it just kind of sorts itself out as people work through their rotations and their training. So to get at this, we interviewed residents, 17 residents from across Canada, asking how they navigated development of their interprofessional competencies in their training, exploring these gaps. We did this using focus groups sensitized by the interprofessional competency framework and CanMEDS and workplace learning frameworks. Interviewed 17 residents from a full variety of years of training, so all the way from first year all the way up to fourth year, and then every single different we had representation from the different groups of specialties. And we found three interesting things. One, that interprofessional learning was happening with trial and error. Second, the presence of it being filtered through this uniprofessional lens. And third, a call to privilege the existing informal learning that was there. So to unpack this a little bit, the first theme, learning happened through trial and error. This resonated across all the transcripts. One participant said, I can tell you that interprofessional learning happens by hook or by crook, which was a bit interesting phrasing. Trial and error. Someone saying trial by fire really struck me. That's a very striking way to define what it's like to learn interprofessional in the workplace. But this description of learning to collaborate by making mistakes, getting something wrong, making someone angry, then doing it differently next time. And my favorite anecdote that I would hear time and time again is a resident who makes a mistake day one of sitting in the charge nurse's chair and then never makes that mistake again. But the main driver here of their learning wasn't any kind of guidance. It was getting it wrong and responding to discomfort, which resonates with some parts of workplace learning. Have inherent tensions and contradictions, and this makes them powerful sites of learning. But trial and error only works when it's safe to make mistakes. And here's where some structural misalignment started to kick in. So, a lot of residents describe this underlying assumption that they were already supposed to know how to collaborate because it's something that wasn't formally included in their curriculum. So, taking it to mean that these skills should be fully formed. This assumption that they're supposed to hit the ground running day one, already know how to collaborate. Residency is about learning all the medical expertise and then, how to do a consult, procedures, but not about the collaboration. And some of them said, we wrote about this in our letters when we applied to residency, how good we were at the interprofessional team. We talked about it in our interviews. So now really it's selected for those of us who are good at it. Now we need to perform. So the idea that collaboration might still be something to learn just wasn't there. And this in part connects to the idea of psychological safety in learning, the shared belief that it's safe to take these risks, because without it, the conditions that let trial and error learning work will collapse. And this is how the structure can work against develop interprofessional learning, because if collaboration is treated as something you're supposed to have beforehand, then there's not really space to try different approaches. It doesn't feel safe to experiment navigating disagreement. The safe strategy becomes falling back on what's familiar when that doesn't work, retreating into the individual role. And the second theme that residents describe the interprofessional learning being filtered through a uniprofessional lens. One very funnily described it as a blind leading the blind. They would look at their peers, their seniors, sometimes even faculty, as to cues to how to collaborate instead of looking for the interprofessional team. And that a lot of what they labeled as interprofessional learning was still about what other professions could teach them. So their framing, not about how to work better together. For example, oh yeah, the pharmacist can teach me about inhalers. The pharmacist can teach me about drug dosing, not about how can we collaborate on shared decision making about medication safety or reducing polypharmacy. So the underlying message remains, learn from others to do your individual job better, not learn with others to improve team function and patient outcomes. And what this really challenges are things like collaborative leadership, shared models of decision making, because residents noted that this approach tended to reinforce the idea of the physician as leader, this traditional hierarchy, someone who listens, integrates knowledge from others, but ultimately makes a final decision. There was little emphasis on shared leadership, on how to distribute authority, co-lead with other professionals, recognize expertise elsewhere, which does really require seeing yourself not just as an individual, but as a team or collective. That being said, there is rich informal interprofessional learning across residency day to day. On the ground interactions, residents felt this is where really meaningful learning was happening. And again, the desire isn't for more things. It's not for more curriculum, more workshops, more simulations, it's for more guidance, more support and feedback around the informal learning that was already happening with one exception. So conflict resolution, which consistently emerged as something residents felt that they couldn't really learn effectively on the job, where role modeling started to fail because they either didn't see it happen because conflict is something to be avoided, or if they would see it happen, it would be someone with senior to them and they felt, they're able to resolve this because they have the authority to do so. My senior, my staff, I don't. So what comes out of this was this idea of needing to avoid conflict. Just do what you can to get through the block and try not to make any sorts of waves. Don't rock the boat. And this is tough because productive conflict, is essential for team functioning. It's how teams negotiate different perspectives, challenge assumptions, make better decisions. But then several residents described this didn't feel safe. A culture is about getting along, not making enemies, and using authority to avoid conflict. So the implication here starts to be that some of these structures are disincentivizing engagement and conflict, maybe because it threatens evaluations, relationships, career progression. And when disagreement and negotiation is avoided, then team orientation, the goal of this, interprofessional collaboration that's laid out in these frameworks is challenged. And the conflict avoidance and individual orientation reinforce each other. Stay in your lane, do your job, don't rock the boat. And that's the opposite of what the definition of interprofessional collaboration actually is. So, if we come back to the case in the beginning, where we have a resident who's encouraged to lead discharge planning, this team and then encounters friction and receives feedback framing it as an issue, this is something you were supposed to do from the start. This is a professionalism issue. It exemplifies how even when informal workplace learning is sort of happening as it's supposed to, we're getting the exposure, they're getting the genuine, authentic tasks to collaborate on. It can inadvertently push learners towards uniprofessional behavior when there's no support for things like developing collaborative leadership, no safety for mistakes. So this is a system working as we've designed it. The resident tried to engage, made a mistake, encountered friction, learned the lesson, stay in your lane, which aligns with what residents described repeatedly as this culture of don't make waves. This implicit messaging of get along, don't challenge, don't risk conflict, just lead into authority when you have it. And across all three levels, framework, curriculum, learner experience, the same pattern emerges. Competencies that fit within a physician lens are well represented. More complex team-based competencies sometimes slip into blind spots or continue to fall through the cracks. And this is happening even in workplace learning. And as we found earlier, the workplace, is where interprofessional learning is supposed to be happening. And 95% of residents and program directors would endorse that. When I draw attention to the quote here, which is from Pim Tunison, and he wrote about a model of how residents learn in the workplace. I made a point I think that is really salient here, which is which competency that gets the most attention in the learning process is a matter of steering the interpretation and construction of meaning in the desired direction. And to me, what this big mapping exercise shows at all the levels is that maybe the contradictions and tensions and ways our educational structures are, they're steering the interpretation and construction of meaning from interprofessional learning in an undesired direction. Uniprofessional framings are steering learning towards intra, so within the same profession, over collaborative competencies. We're prioritizing teaching and guidance that is intra-professional from other physicians, and structural contradictions are disincentivizing key aspects of interprofessional learning. And if we look at this from another theoretical lens, using the interprofessional socialization framework as an example, which describes how learners should develop this dual identity, identifying both with your own profession, but also with the interprofessional team, this process begins with challenging that uniprofessional perspective. But what we're seeing is that the structural contradictions with our educational structures might hinder development of this dual identity, looking at it from this lens. So instead of creating conditions that are challenging uniprofessional identity, our structures might be actively reinforcing it. But to fix structures, we first need to understand them a little bit better, which leads to the next question. So, how do organizational structures within postgraduate medical education facilitate or constrain informal interprofessional learning? What's actually happening, as my thesis supervisor would like to say, in the walls that made this happen, that so consistently steers interprofessional learning the wrong way? To understand this, turn to the hidden curriculum with the very cliched picture of the iceberg under the surface. So what's under the surface, what's hidden, the unspoken norms, values, assumptions within physician education, the set of influences that are working at the level of organizational or educational structure. And to unpack this a little bit further, found a really helpful definition that distills this down to kind of four things to explore: policies, evaluations, resource allocation, and institutional slang or language. So we interviewed 15 internal medicine residents across all the years of training and found three main themes: that interprofessionalism was conflated with the idea of professionalism, evaluation and assessment mechanisms were inadvertently constraining interprofessional learning, and again, this very strong idea of emphasis on physician as an individual. And so many trainees described how programs framed interprofessional collaboration as just being professional. So failure to collaborate isn't a skill to develop, it's that you're unprofessional, which we think back to the case is what happened there. This challenges navigating the disagreements, this challenging navigating this new role as a senior leading the team led to being flagged as unprofessional instead of an issue with interprofessional collaboration. As one resident put it, as a physician, you're supposed to be this benevolent ruler, be respectful, don't get complaints, but that comes at the cost of not really listening or engaging or being part of the real workforce. And they tie this very clearly back to their program, but more broadly, the role college. So sitting at kind of that higher framing level, that idea that this is interprofessionalism as part of professionalism. And this conflation appeared everywhere in orientation, teaching sessions, program documents, evaluation forms, feedback. As one resident said, being unprofessional is like the worst thing that you can be. It's the scariest label, the worst label. And if we think about learning through trial and error as one of the ways that they're navigating interprofessional competencies in the workplace, then how do you make mistakes if making a mistake is being unprofessional? Because unlike something like a lumbar puncture, a procedural skill, errors are expected, they're remediable. Errors in interprofessional interactions become higher stakes. It incentivizes avoiding risk and getting along. So, as one resident said, maintaining professionalism, you feel like you need to cooperate, not really collaborate. And this language, this institutional language around respect and professionalism becomes unintentionally weaponized to suppress disagreement, even if that disagreement could have been constructive. Because if challenging a decision or raising a concern risks getting labeled as unprofessional, the lesson is clear: prioritize politeness. And what I will say is, I really do believe that learning to express and resolve disagreement, conflict, especially, frankly, as a physician, is a skill and a really hard one to do well at that. And this, to me, is informed by my perspective of being on the other side of this as a nursing student and a nurse. It requires actively understanding and engaging with power dynamics and hierarchies, but suppressing all of this in the workplace under the guise of professionalism doesn't allow for that explicit engagement with power and conflict and hierarchy to learn those skills. Now, evaluation and assessment mechanisms are also implicated. So basically, every single resident in the study called out to this idea of a checkbox that, interprofessional collaboration is something you perform once. It's a box to check. You demonstrate it. You sign off. It's something you developed before you started. It's checked off. You move on. You're done. And this ran across evaluations all the way to their ITERs or end of rotation evaluations down to the entrustable professional activities or EPAs and all the kind of evals in between. This message that you already have these skills, they're not something developed over time. There's no need for feedback or growth. We just check it off. It's a minimum threshold to meet, which heralds back to what some in the previous work residents expressed about their interprofessional competencies. I don't see it in my curriculum. It's not formally addressed, so I'm probably already supposed to know it. And along with this comes this idea of reactive rather than developmental, the language used here. Did you clear the bar or not? Did you cause a problem or not? Not how are you learning to work with the team? And if you notice what this reinforces, if you think about this idea of like, did you cause a problem or not? It's not how did the team work through the challenge? It's what did you do? So the orientation stays on the individual, not the collective. And even though now we have, with the advent of competency based medical education, this integration of these collaborative milestones and to be assessed in practice, it still remains quite individualized and reactive, at least from the perspective of learners, privileged with like, did we have a problem or did we not? And the next theme is again this emphasis on the individual, which runs deep and isn't surprising thinking all the way back to the framework level. What gets prioritized? It's the one that aligns very nicely with the physician as the individual. And one resident described it as the values that are communicated to us in our training. It's comes down to this idea. It's our knowledge, our independence. We're solid in our careers, not this idea of relational care, giving off this perception that you're going to be someone who's managing patients on your own. This team orientation is secondary. And this comes with some other pieces. This focus on individual efficiency, within objectives and evaluations and messaging was a little bit ironic because, truth to be told, working well with a team is arguably, for me as an internist, a much more efficient way of doing things. But also this idea that when team and individual goals come into tension, the expectation is clear. Prioritize your individual learning, your medical expertise. One resident gave the example of having teaching sessions scheduled at the same time as their multidisciplinary rounds and feeling like the wrong call based on all the messaging I'm getting is to go to multidisciplinary round. I should be going to my uniprofessional teaching session. And this messaging about improving your own relationships, not you and the team. It's about you as an individual, assessing you as a doctor alone. And then that in turn, for one resident, drove what they turned to focus on. And underpinning all of this is what I think can be described as like a blank page or a messaging vacuum. There isn't a clear or shared language about what interprofessional learning should look like. So it lets all these other influences fill the gap. What's missing fills the gap: the institutional language, the role modeling, evaluation templates, what isn't informal curriculum. It gets pulled from to try and fill this blank page about what the expectations about interprofessional learning actually are. And these all end up privileging this sort of individualistic, physician-centric view of collaboration. So, what does this mean? Across framework, curriculum, learner levels, and deep in the hidden curriculum, this consistent pattern emerges. So, even if we're saying we explicitly value interprofessional collaboration and learning, the educational structures and postgrad, the frameworks, assessments, hidden messaging are continuing to steer towards an uniprofessional orientation. Going back to the idea of interpretation and construction of meaning, it's away from collaboration. But it's not just that team-based competencies aren't being taught, it's that maybe even the opposite is being encouraged. Avoid conflict rather than engage, prioritize individual performance over collective outcomes, value getting along over genuine collaboration, and see leadership as individual authority and autonomy rather than shared power. And Along with this comes not meaningfully attending to power structures, dynamics, and hierarchies. So, to me, what maybe remains most at risk here is precisely what interprofessional learning was meant to foster: the ability to see yourself as part of a team, to engage with difference, to navigate disagreement, and to share leadership. And disagreement, which is recognized for a necessary condition for growth for learners, but is also a valuable part of team function and patient care, has sort of been steeped or designed out of every layer of postgrad. It's not operationalized clearly at the framework level. There's an assumption it'll develop naturally at the curriculum level, but it doesn't. At the learner level, it feels unsafe and scary. And through the hidden curriculum is all this messaging about it being unprofessional and something to be avoided. So maybe the fundamental issue too is that it's a structural misalignment. We're trying to foster relational collective competencies within structures that are fundamentally designed to encourage individualism and autonomy. And this has further downstream ramifications for all of the supposed promise of interprofessional collaboration that I talked about earlier. For patient safety, the things that are supposed to reduce harm, if we think about patient safety, it's shared decisions, speaking up, productive disagreement to catch errors. These are maybe the ones that our educational structures are making it hardest to learn. The calls for action for collaboration keep talking about teamwork to prevent adverse events, but are we supporting the kind of teamwork that does that? And then for workforce sustainability, true collaboration where you genuinely share the load, this is what's supposed to improve team resilience and sustain healthcare workers, move away from this isolation and burnout. But this model of a physician bearing individual responsibility, making individual decisions, that's more likely to drive burnout and attrition and also not really promote the kind of teams that we're seeing are more sustainable and more resilient. And then for the physicians we're training, if we continue to privilege autonomy, hierarchy, and conflict avoidance in our educational structures, we risk producing physicians who are not really ready for interprofessional collaboration, who might be comfortable leading a team in a traditional sense, directing, coordinating, deciding. But that is exactly what interprofessional collaboration was supposed to pull us away from. And, we may not control all workplace structures, which is also the truth. Patient care needs, institutional forces, hospital needs funding, all of these things are bigger than, us as educators and predominate. And we can't go and overhaul the whole system. But I think why this matters to me is that, to a greater degree, we have some control or more control over educational structures. We can advocate, we can push for change here, we can look at our own programs and the way language that we use. We are stewards of our own practice here. So I'll start with talking about some quicker fixes based on all of this, which is, I think, a really easy low-hanging fruit is stop using professionalism as a term for interprofessional learning. It makes the stakes too high. It encourages challenges, collaborating as a personal failing as this big red flag. Being careful in recognizing the outsized influence that evaluation design, the physical design, what's there has, replace checkbox assessment with narrative feedback that allows collaborative skill development to be tracked over time. And along with this, think about flagging excellence, not just deficits. So collaboration should not just appear in feedback when something has gone wrong. And creating opportunities for reciprocal team-oriented feedback to start to reconceptualize the idea of not an individual, but this is a team process. It needs to be a little bit evaluated as a team. So residents have the opportunity to receive and give input for team members, recognizing the caveat that even in the literature, the interprofessional feedback does come with its own set of challenges. And I think very importantly, and underlying all of this is address that messaging vacuum. Let's be explicit, because if we do not define what interprofessional learning means in the workplace, what the expectations, what the objectives are, the hidden curriculum will go ahead and define it for us. And a deeper restructuring, though, because this is kind of like a fresh cone of paint on the walls. But if we're talking about educational structures, as some of the trouble here, then a deeper rebuild, renovation might also be required. So what I take away from this is the idea that maybe we need to reframe collaboration as a learning process, not a trait to demonstrate. So move beyond assessing interprofessionalism as politeness or absence of conflict and make room in educational structures for engagement in productive disagreement and shared decision making. Center interprofessional voices and perspectives in teaching and feedback, not as co-participants, not as sharing knowledge for what's relevant, but as co-teachers and evaluators. And we can look to some of the work in the literature around interprofessional guidance for this. So centering interprofessional orientation can help address this idea of who is a leader and who isn't. And then design our educational structures to enhance psychological safety and foster interpersonal risk taking. So create spaces where speaking up, negotiating roles, working through tension are actually recognized as legitimate and even accessible learning acts, which also means rethinking how we respond to lapses in collaboration. Maybe treating it the way we treat a procedural error, as getting a procedure wrong, as a learning opportunity, not a character flaw. On a harder level, maybe thinking about bringing competency frameworks into closer alignment with relational practice. So, revisiting how uniprofessional competency frameworks, and I use CanMeds here as an example, but revisiting how they operationalize collaboration, expanding beyond this idea of communicating respectfully towards competencies that more explicitly frame and operationalize conflict engagement, shared leadership, role negotiation, and then recognizing if maybe this doesn't fit nicely in an individual oriented framework, that moving to a dedicated interprofessional competency framework might matter. And the last is to privilege the informal workplace learning. So find ways to build in that feedback and support that learners are clamoring for and to build on the rich learning that's happening there. Because the promise of interprofessional collaboration and the point of interprofessional learning has not really ever been about let's get along. It's been about how can our teams function to their full potential and allowing us to all work to our fullest scope of practice. I opened with a resident who learned to retreat when collaboration became risky and relied on the promise of future authority and autonomy to say that's how I'm going to make this work. I think about my own experience navigating these two contradictory truths about who leads and kind of two resulting patterns of collaboration. And think that, these outcomes are to some degree still really a reflection of our educational structures. So to me, kind of the puzzle and the question to solve is how can we reimagine educational structures that incentivize this risk taking, that center collective practice, and that challenge some of these traditional dynamics that still persist? So thanks, everyone. That's the end of my talk. I did want to acknowledge everyone who has supported in this work. Very importantly, Dr. Matt Sibold, who has been involved and mentoring and supervising much of this research and is an active collaborator. Also, Dr. Renee Stallmeyer, who supervised the master's thesis component, and then the rest of the study team who has supported through data collection analysis and also this talk. So thanks very much.
Hey, thank you so much. Thank you so much, Arden, for presenting and everyone for attending and your amazing questions. I think this was an awesome just dialogue and discussion. So thank you, everyone, and I wish you all a great evening. Bye bye.
Bye.
Thank you.